She had been coming to therapy every week for 3 months. She had told her analyst she was committed to the work, that she was desperate to understand her recurring depression, that she would do whatever the treatment required. And yet, session after session, something kept happening. She would arrive late. When she arrived, she would talk about the week's events in exhaustive, neutralizing detail, describing everything with equal weight, making it impossible to identify what was actually significant. When the analyst offered an interpretation, she would agree immediately, with what seemed like genuine insight, and then nothing would change. The next session would begin the same way. Sigmund Freud would not have been surprised. He would have recognized in this patient's behavior a classic and entirely predictable feature of analytic treatment: resistance, the patient's unconscious opposition to the therapeutic process itself. Not conscious obstruction. Not deliberate sabotage. Something more interesting and more clinically important: the mobilization of the same defensive forces that produced the patient symptoms in the first place, now organized against the treatment that was attempting to modify those symptoms. Freud first encountered resistance in his early use of hypnosis and the pressure technique, before free association became his primary clinical tool. He noticed that some patients would refuse to produce associations, would blank out, would change the subject, would claim to have nothing on their minds. Initially, he attributed this to insufficient effort. Over time, he recognized that these blockages were not accidental. They were organized, purposeful in an unconscious sense, and consistently concentrated at precisely the points where the most significant material was located. The resistance was strongest where the repression was deepest. This recognition transformed resistance from an obstacle into a clinical resource. Resistance revealed the contours of the repressed. Its shape in the treatment could be mapped against the unconscious conflicts it was protecting. Where the patient resisted most, the analyst could infer that the most threatening material was concentrated. Working with resistance, not forcing through it but exploring it, understanding it, interpreting it, became central to the therapeutic process. Resistance takes a remarkable variety of forms. The most obvious is the failure to free associate, the patient who consistently cannot say what comes to mind, who edits, selects, and produces polished narratives instead of raw associations. But resistance appears in many subtler and more sophisticated forms. Late arrivals, missed sessions, and forgetting to pay the analytic fee are behavioral resistances, the patient's body and logistics acting out what the mind would prefer not to address. Intellectualization is a particularly seductive form, the patient who discusses their psychology with brilliant analytical precision, engaging all the right concepts and frameworks, while remaining entirely unaffected at an emotional level, the talking about rather than the experiencing of. Paradoxically, the patient who seems most cooperative, who agrees enthusiastically with every interpretation, who appears to be making rapid progress, may actually be demonstrating one of the most significant forms of resistance. This flight into health, as it was called, occurs when the patient begins to feel better early in treatment, before any real analytic work has been done, and uses this apparently positive development to argue, consciously or not, that treatment is no longer needed. The improvement is real but transient. It reflects the relief of being understood and attended to rather than any genuine structural change. Transference resistance deserves special attention. The patient's transference, the reliving of past relationships in the therapeutic relationship, becomes a form of resistance when it is used as an alternative to remembering and working through. Rather than bringing past relationships into language and consciousness, the patient enacts them in the therapeutic relationship, seeking gratification, provoking rejection, or engineering the relational scenario that feels most familiar. When this enactment replaces reflection, the transference has become resistance. Freud's most important clinical contribution around resistance was the insistence that it not be simply confronted or overridden. The analyst's task was to work with resistance, to understand its function, its history, what it was protecting, and to help the patient understand it too. When a patient can observe their own resistance with some degree of curiosity rather than shame, they have already taken a significant step toward the psychological freedom that therapy aims to achieve. Subscribe to Psychology. Theories explained for more psychology breakdowns every week.